Welcome to the ninth module of this series, Developing Awareness of Blind Spots. To recap from the prior module, there are multiple opportunities to incorporate second opinions into routine clinical practice to help radiologists avoid diagnostic errors. Tumor boards and multidisciplinary conferences are a model that already incorporate second opinions. You always have the option of consulting with colleagues for complex or difficult cases, or consulting colleagues in other specialties. Getting second opinions are particularly important for cases involving cancer diagnosis, staging, and restaging. You should also look at procedure requests as an opportunity to provide a second read. One major opportunity to reduce diagnostic errors is implementing a formal process for prospective double reading. While second opinions will not eliminate diagnostic errors, incorporating second opinions for a subset of cases can likely reduce errors and improve patient care. The goal of this module is for learners to develop awareness of blind spots. The learning objectives are to describe common blind spots in abdominal imaging and explain methods to reduce diagnostic errors related to blind spots. A blind spot on a radiological image is an area in which interpreting radiologists are prone to having perceptual errors. The CT below was performed for surveillance in a patient with colorectal cancer after resection. Do you see anything abnormal? I'll give you a hint. Look at the omentum. How about on this image? There is an enlarging peritoneal implant that is missed on 3 consecutive CT exams by 3 different radiologists, all of whom are subspecialty trained in abdominal imaging and have substantial experience reading imaging studies for patients with colorectal cancer. The omentum in the peritoneal surface is a blind spot. Certain cancers aren't expected to spread intraperitoneally, such as renal cell carcinoma, transitional cell carcinoma, and prostate cancer. However, there are instances in which these tumors can spread by this route, such as when tumor cells are spilled during surgery, or the cancer metastasizes to an intra-abdominal organ and then spreads intraperitoneally. This makes it even more difficult to identify peritoneal disease because we're not looking for it. This is a form of attribution bias. The bottom images show peritoneal implants related to renal cell carcinoma that showed up on the immediate postoperative CT on the left and the follow-up CT on the right, both of which were missed. Another common blind spot is a subcutaneous fat, particularly for cancers like melanoma and renal cell carcinoma. 4 new implants were missed on this CT performed after nephrectomy. In the left flank subcutaneous fat on the left-sided image, in the left retroperitoneum in the middle images, and in the right ischiorectal fat on the right-sided image. On this CTA of the chest, abdomen, and pelvis performed for severe aortic stenosis and TAVR, the radiologist misses a transitional cell carcinoma in the left renal pelvis. For this case, there is a long structured report with a single line for abdominal non-vascular findings. This is not an effective way to address known blind spots. The renal pelvis is a blind spot because soft tissue growing within the pelvis often mimics a prominent extrarenal pelvis, particularly on non-contrast CT exams. Incidental colorectal cancers are frequently missed on CT exams performed for other reasons. Make sure you look for bowel wall thickening and hyperenhancement. These are 2 different examples of missed sigmoid colorectal cancers. In a recent malpractice case review by Coveries, looking at claims over a 5-year period, they found the most common allegations of failure to diagnose involving radiologists were for breast, lung, colon, pancreatic, and kidney cancer. The pancreas is a blind spot where incidental cancers are frequently missed. Remember that the pancreas is oriented obliquely, so if you don't scroll through the entire pancreas, you can miss exophytic neuroendocrine tumors coming off the top or the bottom. The left-sided image shows you an example of a neuroendocrine tumor that was missed. Secondary findings are often missed or misinterpreted when a focal mass is not visualized. The right-sided CT was performed in a patient with esophageal cancer undergoing surveillance. There is abnormal enhancement in the pancreatic tail with ductal dilation and abrupt transition. This turned out to be pancreatic adenocarcinoma, but was missed by the interpreting radiologist. Small bowel tumors and metastases without obstruction can also be missed. There are specific types of cancers that metastasize to the bowel such as melanoma. For these patients, always evaluate the bowel and subcutaneous fat very carefully. In this CT, you see a small bowel metastasis related to melanoma that was missed by the interpreting radiologist. The pedicles are a blind spot for subtle osseous metastases. The bottom two images are similar appearing pedicle metastases in patients with cholangiocarcinoma on the left and renal cell carcinoma on the right. One suggestion is as you're scrolling through the spine, separate out the vertebral bodies and the pedicles as you go through to make sure that you can focus on and find subtle findings. Modifying structured reports to include fields specific to blind spots is one approach to reducing this type of diagnostic error. I talked about these in a prior module, but want to talk about them again because this is a very important concept. You can have a field for the scout view because many radiologists don't routinely review the scout view for CT exams of the head, neck, chest, abdomen, and pelvis. You can have a field for lower lobe pulmonary arteries. Remember, incidental pulmonary emboli are seen in 10% of patients with cancer and 9% of patients who are inpatients. You can have a field for the peritoneal surface. Peritoneal implants are one of the most common misses in departments who do a lot of cancer imaging. You can also have a field for the subcutaneous tissues in order to find subcutaneous metastases, particularly for cancers like melanoma and RCC. While pre-filled templates are perceived as more efficient, they defeat the purpose of using dedicated fields to reduce errors related to blind spots. This is a case I showed in a previous module of a missed pulmonary embolus in a patient with cancer. The template already had no pulmonary embolus pre-filled. You want to get rid of that and have two different fields for mediastinum and lower lobe pulmonary arteries that are blank. Diffusion-weighted sequences and MRI exams of the abdomen and pelvis can reveal subtle metastatic disease that is unexpected. Make sure you review the entire field of view for diffusion-weighted images. Don't just try to characterize a focal lesion that you've already seen on other sequences. You see trends and misses of liver lesions, incidental colon cancers, spine lesions, and peritoneal disease that are missed but obvious on the diffusion-weighted images in retrospect. To summarize, developing awareness of blind spots can be accomplished by any of the following. Follow up your cases to identify when subtle findings are missed or misinterpreted. Develop a robust peer learning system that focuses on identifying opportunities for improvement. And review articles in the literature that discuss common blind spots and what you can do so that you don't miss them. There are interventions that can help reduce blind spot errors. Use dedicated fields and structured reports to ensure that radiologists remember to check known blind spots. And review the entire field of view for diffusion-weighted images to reveal unexpected findings. In the next module, we will discuss how to avoid communication failures that lead to delays in diagnosis and treatment.